My name is Deborah Lawson. I'm the compliance officer and the HIM director. Um, Thank you all for coming today. Thank you all for wearing your black and white. And I know you probably all wonder why we call it's a black and white affair. One reason being that documentation is simply black and white. There are no gray areas. And so we felt like today we'll just get back to basics and go back with our documentation, making sure everything is documented according to standards. And that's why it's called a black and white affair today. So I really appreciate you all, in lieu of the theme, dressing accordingly. So without further ado, we're going to bring Xandra Hampton up, who's going to get this party started. So let's give Xandra a hand.
Okay, well, good morning, everybody. Today, you will learn some valuable information on documentation. First of all, I would like to know, why do you think documentation is so important? Anybody? Why do we have to document? Very good. Anybody else? If it's not written, it didn't happen. Absolutely. And just to let you know that CMS is one of the only national organizations that has written the standards for documentation. So most of all of the other companies, insurance companies, Medicaid, normally follow these regulations. So, and I know you'll see some documentation guidance with your national organizations as well, but CMS set the standards for documentation. So with further ado, it is very important that when you read CMS's guidelines that you understand what some of the actual terminology is. So first of all, they have written definitions of what a physical therapist assistant, OT assistant, and ST is. So you need to make sure that when you are practicing in your state that you follow and you adhere to these guidelines. A physical therapist is a person that is licensed by their state, has graduated from an accredited PT program, has passed the national exam, and they are eligible to practice in the state of which they are licensed. Physical therapy assistants is the exact same, but they must have graduated from an approved PT curriculum and passed the National Physical Therapy Assistance examination. And OT is an individual who is licensed and has graduated from an accredited OT program and is eligible or has passed the National OT exam by the NBCOT. OTA is a person who is licensed unless licensure does not apply. In some states it doesn't. Have graduated from an OTA educational program and is eligible or has successfully completed the NBCOT for occupational therapy assistance. ST, a qualified ST is a person, and this is for the purpose of billing for Medicare, and it's a little bit different. A speech-language pathologist must have the education and experience required for a CCC granted by the American Speech Language and Hearing Association, or they've met the educational requirements for certification and is in the process of accumulating the supervised experience required for certification. Now let me say this. For a speech-language pathologist, Medicare does not require you to hold a CCC. However, you must have met all of the requirements for a CCC, which means that you graduated from an accredited university, that you completed your CFY, You submitted all of your work to ASHA for a CFY after completion, and that you are eligible for a CCC and to become a member of ASHA, but you chose not to. If you choose not to be a member of ASHA, you must maintain all of your documents throughout your entire career, because without those documents, you are not eligible to bill for any Medicare services. And I'm saying this because we've had a situation with a speech-language pathologist in another state that did not have a CCC. And during the investigation, we realized that not only did she not have a CCC, but she did not, the university that she graduated from was not accredited. So she was never eligible to complete a CFY and never received it, never completed any of that. And she's been practicing for 15 years and has to start all over again. So please adhere to these guidelines, just so you all know. Okay, CMS, in their regulations, they talk about active participation. And when they mean active participation, it means that the clinician must participate in the treatment for at least one billable session on at least one day of treatment. That's what that means. They go on to talk about an assessment, what that is, but certification, and this is very important. Certification means that the physician or the nurse practitioner approves the plan of care, and that the certification requires a signature and a date on the plan of care. Now, Medicare will deny your claim, and we've had some claims denied recently because the plan of care was signed but not dated. If the plan of care is not signed and dated, it is not a valid plan of care. And we're going to talk about this a little bit later. Clinician. CMS, in their regulations, when they are talking about a clinician, they use the term to refer to a therapist, not an assistant, not an aide, or any other personnel. So in their regulations, when you see the word clinician, they're talking about the registered therapist, not an assistant. And it's very important that you understand that. Clinicians make the clinical judgments and are responsible for all services they are permitted to supervise. Services that require the skills of a therapist may be appropriately furnished by a clinician, that is, by and under the supervision of a qualified physician or nurse practitioner, where the scope of practice, state and local law allows it, and their professional training is judged by the Medicare contractors as sufficient to provide it to the beneficiary skills equivalent to a therapist for that service. So a clinician by CMS is a registered therapist, not an assistant. And this is important because in their guidelines for documentation, they talk about what part of the progress note has to be written by the clinician. Complexities. We know that our documentation must be of such sophistication and complexities that only a therapist could provide the service. And so they tell you what the definition of complexities means. They are complex factors that may influence treatment. Example, they may influence the type, the frequency, the intensity, or the duration. Complexities may be represented by diagnosis, which is ICD-9 code, the patient factors such as age, severity, acuity, multiple conditions, and motivations, or by the patient's social circumstances, such as the support of a significant other or the availability of transportation to therapy. A date. Now, this is important because CMS goes on to talk about how the date may be obtained. A date may be in any form. It may be written, stamped, or electronic. The date may be added to the record in any manner, at any time, as long as the dates are accurate. That is important. If there are differences, you should both refer to the date of service that it was performed and the date the entry to the record was made. So this is very important. For example, if a physician certifies a plan and fails to date it, the staff may add received date in writing or with a stamp. Everybody got that? If a physician fails to date a plan of care, you, the therapist, may write the date as date received. That is valid. Never put a plan of care on a chart in the medical record without ensuring that it is signed by the physician and dated. Also, if the physician faxes the referral or the certification or recertification and forget to date it, the date that prints out on the fax is valid. If services provided on one date are documented on another date, both dates should be documented. So if you fax your plan of cares and they fax them back, and he forgets to date it, the date came back becomes valid. Okay, they go on and talk about evaluations, reevaluations, the patient, qualified professionals, treatment day. Let me go back to qualified professionals. A qualified professional means a PT, OT, speech language pathologist, physician, nurse practitioners, clinical nurse specialists, physician's assistants, licensed or certified by the state to perform the therapy services. A qualified professional is the assistants. So when you see the word qualified professional in the documentation regulations, they are referring to assistants as well. A treatment day. Medicare defines a treatment day as a single calendar day on which a treatment or evaluation or reevaluation is provided. This could be multiple visits, treatment sessions encountered in a treatment day. Okay, any questions about the definition? It is very important that you have a clear understanding of these definitions because they use all of these terms in their regulations.
When you said that they shouldn't ever put a POC in the chart without the physician's signature and date, what if they put it in there and it's flag for the physician? You're saying do not.
Some facilities have a system for getting your paperwork signed. You should follow facilities protocol for getting paperwork signed. While the original, if the facilities protocol is to place it in the chart and flag it, then that's what you do. Now, if the plan of care is sent out of the facility for signature, you should put a copy of that plan of care on the chart and flag it as out for signature or OFS. When that original plan of care comes back, you should remove the copy that says OFS from the chart and replace it with the original valid plan of care. So if your facility's policy or system is to place the plan of care in the chart and flag it, that's what you do. So, and everyone in here should know what their facility's systems are for getting the paperwork signed. It's not the same in every facility. So you should know your facility's system. Yes?
Once you follow that protocol, and especially if it's flagged to be on the chart, signed by the physician, is that the end of our responsibility as far as how long it takes the physician to actually sign it? Or are you gonna maybe get staff?
Well, let me say this. If it's physical therapy's paperwork, or speech paperwork, or OT, it is always your responsibility. It's your paperwork, it's your services. If you have building with signatures and doctors and dates, or maybe medical records supposed to be taking it out, and medical record says, I'm not taking therapy paperwork out. You need to communicate with your RCD so your RCD can communicate with the administrator or the DON, or you should go to the ED or the DON. But the paperwork, regardless of who takes it out and gets it signed or who doesn't do it, it's your responsibility. It's your paperwork. It is your section of the chart. Because when Medicare denies the claim, they're not going to be coming looking for the medical records person. They're going to want to see the physical therapist who provided the services. So you are responsible, and you should ensure, I know different facilities have a lot of different systems. You should, if you have techs in your building and the rehab tech does all of the filing and they are responsible for putting the paperwork on the chart, at some point in time, as the treating therapist, whether you do it when you renew your plan of care or at discharge, you should always go to your section of that chart and go through every piece of paperwork. You have Cassandra right there in front of you to make sure all of my progress notes are on the chart, and to make sure all of my plan of cares are on the chart, and they're signed and dated. Any plan of care that's not dated or signed, you either need to send the plan of care out again, but it's your responsibility, not the rehab techs. It's your job to basically oversee that. It's your paperwork. Everybody got that? Yes.
How important is it to have the date before you, before you provide a service, or is that necessary?
The date, like on,
The date of the, say, for the plan of care, you go ahead and start,
you can do
the
that.
doctor signs it, does it need to be dated for the day you did the evaluations to come?
We're going to talk about that. Medicare says that the certification should be signed within 30 days. Now, that's Medicare. Some companies' policies are different. Some companies have policies that the plan of care must be signed within the first 14 days. And Medicare talks about how important it is that for the certification that you send it out as soon as possible to get it signed. Here we go. Timing of the certification, great question. Medicare says the provider or supplier should obtain certification as soon as possible after the plan of care is established, unless requirements of a delayed certification are met. And we're going to talk about that later. As soon as possible means that the physician shall certify the initial plan of care as soon as it is obtained, or within 30 days of the initial therapy treatment. Clear as a bell. Now, you don't wait. As soon as you write that plan of care, you follow your facility's procedures for getting it signed and dated. Now, let me say this. It is okay. Make sure that anything that requires a physician signature, you should always flag where you want the physician to sign. We've seen plan of cares where the physician has just signed at the bottom, where we don't know, was that just a scribble? It didn't say physician signature. The therapist never drew a circle around it. If a physician signs a plan of care outside of the physician sign here box, and they mistakenly sign at the bottom, you should always draw a circle around it and arrow it back up to the physician's signature. We had another claim that was denied because there was no physician's signature, but after we reviewed it, it was at the very bottom. But CMS doesn't know that, and the therapist never, the person reviewing the paperwork before they sent it to Medicare never drew a circle around it and arrowed it back up. So that's really important. And make sure that when you put the sticky note that says sign here, please date it, and sometimes we can ask them to please date it a certain date. Make sure that it's flagged. Make sure you only use a yellow highlighter. Certain colors, when you copy it, because a lot of times when Medicare requests the paperwork, we have to make copies. If it's green or that dark blue, the signature becomes obscured and they can't see it. So always use a yellow highlighter if you highlight where you want the physicians to sign, because yellow will copy clear. When the paperwork comes back and say you put a sign here and please date sticker on it, please take the stickers off. We have seen plan of cares copied and ready to be sent out to, and there's the sign here, please date it, copied right onto it. That's just our system for getting things signed and dated. Please remove it when it comes back, okay? Okay, all right, they go on to say that since payment may be denied, they tell us that payment may be denied if the physician does not certify the plan. The therapist should forward the plan to the physician as soon as it is established. That means if you write it today, you need to follow the procedure for getting it today. No, if it's after 5, you might want to do it the first thing the next morning. Evidence of diligence in providing the plan to the physician may be considered by Medicare contractor during the review in the event of a delayed certification. And I know Mid-South has a physician tracking log. It is required by this company that you utilize the physician signature tracking log. How many, with show of hands, how many of you all know what I'm talking about? How many of you use it? I don't mean just put the patient's name on it and it's blank. I mean, how many of you use it? And if we ask for the tracking log, there's actually information with a show of hands. Okay, good. Now, after this training, everybody's hand's gonna go up, right? Y'all, this is so important. This is critical. Signatures and dates, keeping a tracking log, because you may have gotten it signed, it's done, it's 2012, and they're requesting paperwork from 2009. Well, the patient's been discharged and the records have been lost. Or the original came back, I got a record that it came back, but I can't find it. What do? That physician signature tracking log will help us get claims paid when plans of cares are missing dates and signatures. So, and it's right there, Medicare says it. That's why they require you to use the physician tracking log for the paperwork. So your RCDs, when they're making rounds, they're gonna ask for your physician signature tracking log book. And every patient on caseload should have something written on it, whether 700, the date you sent the 700 out, the date you sent the 701 out. They're gonna be looking for that. Every patient log should have something on it. And that's a system to basically help you as well. So if you send paperwork out and you have patients on caseload, you need a system to help you to remember, I need to check this log to make sure that the paperwork, number one, that I sent it out, and number two, that it has come back, because CMS says the certification must be signed within how many days? 30 days. So if you sent something out in March, it's May. You should be checking that log ago. I don't have my plan of care back. I have a record where I sent it out. So that helps you keep up with your paperwork. And it's also something that CMS will help us, will validate the claim if we have a tracking log. Okay, timing. Timely certifications of the initial plan is met. Timely certification is met when the physician or nurse practitioner certification of the plan is documented by a signature or verbal order and dated within 30 days following the first day of treatment, including the evaluation. That's considered timely. And y'all, we will get claims. Claims will be denied. They will deny them. We're working on claims right now where the physician did not, they signed it but didn't date it. Medicare will deny the claim. They don't even have to look at it. They'll say, and what the denial reason was, not a valid plan of care. In order to bill for Medicare services and to be reimbursed, you must have a valid plan of care. If the order to certify is verbal, it must be followed within 14 days by a signature to be timely. A date noted of the order to certify the plan should be made in the patient's medical record. Now, for orders, we follow the facilities protocol for obtaining orders. Whatever that is, you need to follow that, okay? Have problems with your physician orders being signed timely, you need to have a conversation with your DOR and your RCD, and they'll handle it, okay? Every building has a rehab director. Any issues you're having with orders, plan of cares, dates, anything getting signed that's facility related, you should be going directly to your DOR. And if your DOR needs further assistance, she will contact the regional director. All right? Okay, delayed certification. Delayed certification and recertification's requirements shall be deemed satisfied when at any later date a physician makes a certification accompanied by a reason for the delay. For example, you have a doctor that's on vacation. He's out of the country, and there's nobody else in his office that will sign for him or that can for him. In the event that that happens, he can date a reason, and it's called a delayed certification, and Medicare will honor that plan of care if there is a valid reason. A delayed certification should include any evidence that the provider or supplier considers necessary to justify the delay. For example, certification may be delayed because the physician did not sign it or the original was lost. That tracking log, again, becomes important because you have to have proof of when you send it out and how many attempts you made to try to get it signed. Yes? You can do that as long, and then also it would be helpful, you guys, in your daily treatment note that you would make mention of that. And we're going to talk about that a little later, how you should document. Things like that happens, you need to document it in the daily treatment note as well. Okay. In the case of a long delayed certification, the provider or supplier may choose to submit the delayed certification some other documentation such as an order, a progress note, telephone contacts, and things like that, indicating the need for care, that the patient was under the care of a physician at the time of treatment. So they are asking for some proof that the physician was aware that the patient was being seen and was under the physician's care. Okay, any questions about delayed certification? Okay. So what are you going to do when are you going to send your plan of cares out for physician signatures? Right here. When are you going to send it out? No, say that again. As soon as you do it. How many days from the evaluation do you have to get the plan of care signed and dated? 30. If the plan of care is signed and not dated, is it valid? No, it's not. Will you ever put a plan of care on the chart that the physician has signed but failed to date? No. What are you going to do? You can date it, the date received only, but you need to make sure that the date received is within that 30-day window, okay? If you have problems with the dates on your plan of care, you should always see your rehab director, okay? Don't take it upon yourself to just handwrite it in. Don't do that. But do not place it on the chart either. It's not valid. So any issues you have with getting your plan of cares dated, you, the therapist, should go to your rehab director. And your rehab director, based on the facility's policies, will guide you in what you should do, okay? But it's not valid unless it's dated. All right. Okay. Now let's get to the good part. This is the actual documentation guideline of CMS. CMS says that everything we do must be reasonable and necessary. Those, I know you've heard those words all of your life, reasonable and necessary. What does that mean? It's reasonable, I'm doing it, not necessarily. Reasonable and necessary for the purpose of this training, reasonable and necessary is services that is reasonable and necessary for the diagnosis of a treatment of an illness or an injury, or to improve the functioning of a malformed body member. And that's what CMS says. Medical necessity. Everything we do, and Medicare will deny claims, and claims will come back, they'll say, not medically necessary. Well, it was medically necessary. I did it. Well, obviously, you didn't paint a clear enough picture for Medicare so that they will understand that the services that you provided at the time were medically necessary. In order to establish medical necessity, there are several things involved. One, you need to document the medical necessity statement on your initial plan of treatment, and it should include the areas requiring skilled intervention as well as what risk factors are associated if the resident does not skilled intervention. So you should say, think about it this way. You need to document, you need to tell Medicare if the patient does not receive physical therapy services, the resident is at risk for skin integrity issues, contracture problems, speech therapy. If the patient does not receive skilled speech therapy services, the patient is at risk for malnutrition, dehydration, and possible aspiration. Those are medical necessity statements. Now, when you think of medical necessity, you should think of medical necessity when you're screening a resident. When you go to screen a resident, you are looking for a problem related to your discipline that interferes with something functional. And the first question you should ask yourself, here is a patient that is bedridden, on a feeding tube, that has severe dementia. There is no functional maintenance plan for this resident. What is this patient at risk for if I do absolutely nothing? What's going to happen to this resident? They will probably develop skin breakdown, wounds, contracture problems, all types of issues. That's the question you should ask yourself when you're screening a resident and you see a problem. Because a lot of you all go, well, I done picked this patient up 3 or 4 times. I'm not going to pick this patient up again. They're not going to do anything, da, 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 da. But every time you go and screen a patient, you should be looking at a patient with clear, clean eyes as if you've never seen the resident before. If you do that, you will ensure that you give every resident the opportunity to have their needs met. Just because they didn't work with you 6 months ago or 2 months ago doesn't mean that you're going to have problems now. You are obligated under the law. If any resident needs any type of therapy services, by law, you are obligated to provide those services. Now, when the surveyors come in and find problems and see that you've never worked with that patient, they'll make sure, because the facilities will end up getting tags. Don't overlook those falls, the weight loss people. When you screen, you ask yourself, what is the resident at risk for if I do nothing? And if there is a risk factor that will cause further decline, you are obligated to evaluate, to stop the screen, obtain a physician order, and evaluate. That is the medical necessity statement. And you have to document that. And we're going to talk about that when we get into the documentation training. It is very important that you tell Medicare, without your services, the patient is at risk for whatever that may be. Okay, and these are some medical necessity statements. Physical therapy. Without skilled PT, the resident is at risk for increased dependence on others for care, further functional decline, and increased safety concerns. OT. Without skilled OT, the resident is at risk for increased dependence on others for all self-care. Speech therapy. Without skilled ST, the resident is at risk for malnutrition, dehydration, aspiration on foods and liquids. The resident is also at risk for decreased ability to communicate basic needs and wants to staff, family, and friends. You have to document a medical necessity statement on your initial plan of care that helps establish medical necessity. Okay, the following conditions must be met to be considered reasonable and necessary. The services shall be considered accepted under the services shall be considered under accepted standards of medical practice to be specific and effective treatment for the patient's condition. It must be of such level of complexity and sophistication that the services could only be performed by a therapist. Services that do not require the performance or supervision of a therapist are not skilled and are not considered reasonable and necessary. CMS also says, this is important, that even though if there is an assistant providing the services, they assume, they will pay for the claim, but they assume that the services were properly supervised. So what that means is that whatever your State Practice Act says regarding for assistance, you need to follow that. Because if you don't follow your state guidelines for supervision, Medicare will not pay for it. And if they find it, they're going to take back all that money. So it is very important that you follow your State Practice Act for supervision, assistance. It is your responsibility to develop a system with your registered therapist with supervision. If you have a system for supervision, you should follow that. If you don't have one, you need to develop that. If your registered therapist is on vacation and a PRN is going to be coming in, you assistants, it is your responsibility to make contact or help that PRN person know what the systems are so that they can get you supervised in a timely manner. So, you know, how many times have I hear, well, they didn't supervise me. Well, did you treat? Yeah, well, you shouldn't have. So why did you treat? Well, you know that you didn't, that the supervision ended on after Friday, you couldn't treat. So by law, you have to follow your Practice Act guidelines for this. And I can't talk about this enough. If you have issues with supervision, who should you be talking to? You got somebody in your building before you can get to your RCD, your DOR. Y'all, you have a manager in your building. Your manager is your DOR. They know what they're supposed to do. Your DOR will help establish a system and will make sure that gets done. You should be going to your DOR, and if your DOR has problems, she will go to the RCD. But you all have a direct manager in your building. It is the DOR. So any issues you're having with supervision or anything related to resident care, code of conduct, what, be talking to your DOR. And your DOR will handle that problem for you. Yes.
Sandra, if the PT establishes a plan of care and say gait training is not a part of it, but when you walk the patient, you find they can ambulate it. But can you still bill for that?
No, you cannot. What you should do is, his question was, he asked the question that if PT evaluated a resident and gait training was not a part of the treatment plan, and he noticed when he's walking the patient there are some problems, can he bill for it? Can he work on it and bill for it? The answer is no. Y'all, the purpose of the supervisory visit And you don't have to wait till the supervisory visit to call your supervising therapist. Anytime you see an issue, a problem with the patient, you should be talking to your supervisor or picking up the phone and calling that person right then and saying, I see some issues with this resident's gait pattern, and you don't have a gait goal, and that discussion should be happening. So that if deemed necessary, the physical therapist, the supervising therapist should be adding a goal. If you see a goal that you think is not appropriate, during your supervisory visits, that's the conversations you should be having. And you don't have to wait till the supervisory visit. Your supervising PT should be available to you anytime during the day, on any given day. And you can pick up the phone and call them if they're not in the building. And you should be doing that. And make sure that you document in your daily note that you contacted the registered physical therapist regarding gait issues with Ms. Jones. That is not currently a part of the plan of care and what the discussion was. Every time you do that, you should be documenting that. If you call them and say, Ms. Jones has met their gait goal, the goal needs to be upgraded to increase the level of complexity to progress the patient towards their long-term goal. If you call the PT and say that, you need to document that. So when they do that progress note, they know that that goal needs to be updated or needs to be upgraded. So don't wait until this, and I'm gonna tell y'all, sometimes supervisory visits, some of the conversations that should be happening on some of these patients that's not making progress, the conversations are not the way that they should be. You, the treating therapist, should be giving that registered therapist all the information they need to ensure that they provide the best care. And sometimes you don't communicate, you don't tell them everything, and you should. And if you can't remember, in your daily notes, make notes. That's what daily notes are for. Things that you see, so when I have my supervisory visit, I can inform them about this. Or we talked on the phone, I can pull those notes out, so when they come to do my sup visits or countersign notes or whatever, that information is already written and is there. It's like a tracking system for you. And it helps them to remember what they talked about and what they're supposed to do. Okay. While a beneficiary's particular medical condition is a valid factor for deciding if therapy services are needed, the beneficiary's diagnosis and prognosis should never be the sole factor when determining if services is or is not skilled. The key is whether the skills of a therapist are needed to perform the treatment. That's the key. Now, a lot of times we'll get denials that will say services could have been performed by a CNA or by restorative. And they say that because of how we document. How many times have I seen in a note where patient performed oral motor exercises? Any Joe Blow off the street can do oral motor exercises. That's not skilled. But when you say oral motor exercises provided, worked on lingual, labial, dental to improve mastication during the oral phase of a swallow, now those oral motor exercises just became a skilled service. When you say PT ambulated patient down the hall 50 feet, that's what a CNA does. All you're saying is that you walked the patient 50 feet. That is not skilled. But when you say ambulated patient down the hall on stride, cadence, weight shifting, and balance during gait, that's skilled because only a physical therapist would know that. When you say patient performed ADL or ADL retraining for dressing, all that says is you got a patient dressed. That's what a CNA does. There's nothing skilling about that. But when you say during upper body dressing, instructed patient to don dominant side, then left side, use the reacher and other adaptive equipment and different techniques for dressing, only an OT would know that. So your documentation is what determines if the services performed were skilled or not. And we fail because we lack in how we document skilled services. Because unfortunately, Medicare doesn't have the opportunity to come and see you treat. And I'll watch a treatment, it is wonderful. I mean, the therapist was just outstanding, did all these wonderful techniques with these patients, approaches. You read the documentation and it looks nothing like what I just saw. So then I go and have a conversation with them, and I said, now, when you had that stick and you were doing all these exercises, because I'm speech, what were you working on? Scapular, they started naming. I said, I don't see any of that in there. I don't see that documented anywhere. So that's what Medicare means when they say that the services must be of such complexity that only a therapist could have done it, and it's how you document it. And we're going to learn that today. We're going to work on that. Okay. It also says that there must be an expectation that the patient's condition will improve significantly in a reasonable period of time. That the services must be necessary for the establishment of a safe and effective maintenance program. Now, Medicare says we should use our clinical judgment in determining, do we anticipate that this patient will make further gains, or have they reached their maximal functional level at this time? You should be using the objective measures, which means the measurement, your previous measure from last week to this week measurements. You should be looking at that and ensuring, number one, that the patient is making progress. Have they plateaued? Have they regressed? And if they have, what are you doing about it? And you have to document that. And once a patient goes so far, you have to use your clinical judgment in determining that the patient is going to continue to make progress because you're the experts. Okay. Maintenance programs, y'all, we're going to talk about that. Medicare pays for a maintenance program. You can. It is a reimbursable service. And there are some patients that you pick up that are like the bedridden patient that's on a feeding tube, that's nonverbal, that if you screen that patient and that patient does not have a functional maintenance program, you should be evaluating that patient and determining what that patient needs in service, and train the CNAs and the nursing staff on ranging the patient or turning the patient or different technique, because they got some skin integrity issues going on too, that, and then in servicing and training them and writing up that functional maintenance plan. That is reimbursable. Our teaching is reimbursable, and you should have documented record of that the CNA or the nursing staff was able to perform with 100% accuracy. If they're at 50 and you go in there and you're training them and you are constantly having to intervene, they don't have it, and you have to document that they still require the skills of a therapist to provide skilled instructions on the transfer technique. That without those skilled instructions, the patient remains at risk for falls. And you continue to train. You always train. You know when they have mastered it, when you go and say, okay, let's go down to Ms. Jones' room, we're going to do our treatment. And you walk in there and the CNA is engaging the resident and you don't have to intervene and stop at all. It's time, they got it now. They've mastered it 100%, you can discharge with a functional maintenance plan. And every resident on caseload should have a functional maintenance plan. Every resident on caseload at discharge should have a functional maintenance plan for all disciplines. If you discharge, if you pick a patient up and they have problems with gait, dressing, related to balance, range of motion, and you do not educate the CNAs and nurses on the problems, at the beginning of treatment, it may be something simple, like reminding patients to lock their brakes on their wheelchairs, or only ask the patient yes/no questions. It should start wherever you are in your treatment. That's how your education should go with your CNAs and your nursing staff. And you should be documenting that you are educating. As you progress in treatment, what you educate them on should become a little bit more complex, because as you progress in treatment, your treatment becomes more complex. And by the end of treatment, you should have educated them on everything they need to take care of this patient. And there should never be anything on that functional maintenance plan written that you have not already educated on. If it is, you didn't do your job. And it's simple. Your functional maintenance plan is, you write, what will this patient need to be able to do to maintain where they are at discharge? For example, the resident, and it needs to be, yeah, and when you write it, it should be in layman's term. Please don't use complex PTSD terminology. Make it simple. Just say the nursing staff will remind residents or monitor residents during all meals to ensure a chin tuck is being performed during swallow. Or during morning ADLs for upper body dressing, CNAs will ensure that the resident maintains proper range of motion. And what that means is, and you need to write it, and when you are educating the CNAs, you need to make sure that whatever you need them to do, it can be incorporated in something that they're already doing, so it's not an added task to their day. And a lot of times you have to demonstrate, for example, upper body dressing. Okay, the patient needs to maintain range of motion in their shoulders. So what you do is you go in and say, okay, I'm going to teach you how to do range of motion without even doing range of motion. You're going to be getting this patient dressed, and she won't even know she's doing range of motion at all, okay? So when you get her dressed, instead of just bringing the shirt closer to her and letting her stick her arms in, you need to ask her to extend her arms all the way out. Okay, now raise it up just a little bit so I can slide your shirt down or whatever. Patient's getting range and they don't even know it. So it's all about how you instruct, how you train. Everything you want the CNAs to do, you need to say, okay, now I know I'm going to get slack from this, but I need to show them how they can do this and incorporate it into something that they're already doing, so it won't seem like something extra that they have to do. And everything we do for a patient has to be related to what? Has to be related to everything we do in a skilled nursing facility must be, say it again, must be functional. You can't just work on gait if it's not functional. Everything we do has to be tied to something functional. So think about that when you're doing your maintenance plan.
Does the maintenance plan referable to restorative care? Or is that different?
Okay, he says, his question is the maintenance plan referable to restorative? Let me say this. Restorative program is a nursing program. Your job is not to determine if the items on the maintenance plan is to be carried out by the CNAs or by the restorative program. That's not your job. Your job is to train all the CNAs, the charge nurses, the restorative nurses, and the restorative manager. That's your job, is to train all of those people. When you write up that plan, you need to give a copy of that plan to the restorative nurse and to the charge nurse, and the original goes on the chart. They decide if portions of that plan is going to be given to the restorative people, or part of that plan is going to be care plan because the CNAs are going to be doing it. Your job is to train the restorative CNAs, the restorative nurse, all the CNAs that take care of that resident, not just the AM shift people. People, they have to get undressed and eat evening meals. Don't forget about that 3 to 11 shift, okay? And you have the entire 8 weeks of treatment to touch base with all these people. And you go, I can't get to all these people today. Well, how long you been treating the patient? 6 weeks. This your first time thinking about talking to a CNA. Training starts when? When do you start educating? On what day? On the first day. Training starts the first day of treatment. And it does not end until the last day. And it's not just the CNAs and nursing staff. Don't forget about the resident's family and the patient. Okay. Reasonable and necessary also talks about the amount, frequency, and duration of the services too. Must be reasonable. And we just talked about the maintenance plan, and I'm not going to go over all of this. We just explained it. But the skills, the specialized skills, knowledge, and judgment of a therapist would be required, and the services are covered to design or establish the maintenance plan to assure patient safety, train the patient, family members, and or unskilled personnel, and make infrequent but periodic reevaluations of the plan. It is reimbursable. There it is in writing. So, today, when we leave, every patient, you're going to go back and you're going to start training every patient on caseload. And before you discharge, you're going to make sure that every patient has what? A functional maintenance plan. When you are training the patients, when you're training the family or the CNAs, whatever you train them on, you're going to bill that under that CPT code. So if I went in and talked to them about range of motion and exercise, I'm going to bill that on the therapeutic exercise. And on the therapeutic exercise for the treatment note, I'm going to document what I did with the CNAs and what I trained them on. If I educated them on compensatory techniques, such as a chin tuck, sitting upright at a 90-degree angle, making sure that they use alternate sips and bites, I'm going to bill that under my dysphagia treatment. Now, let me say one of the beautiful things about education and training. Because it is critical for those of us that are working in a skilled nursing facility that every day a resident is in an assessment. Every day. Let me say that again. Every day, a Part A or Part A-like patient is in an assessment, which means that every 7 days, we have assessments called a COT, a change of therapy, that may affect our payment or may not if we don't maintain the same number of minutes. So when you have a patient that is sick, that says, or that's not feeling well, or that says, I don't want to come to treatment today. A resident, unless they are out of the facility, we should never see an R on the log. Because even when the patient is sick, do they shut the door and say, okay, this resident is sick, no CNAs will give care to this resident today? Does that ever happen? Absolutely not. Because even when a resident is sick, they still have to be toileted, they still have to be fed, they still have to, all these things, they still get them dressed. Even if it means changing their nightgown, they still have to be changed. Care still has to be provided even when a resident is sick. So, with that being said, because of the maintenance program and because education is required, when a patient is sick, what are you going to do? What are you going to do? And you can also do education. You might not be able to do any true patient to therapist treatment, but the patient will be treated that day because you're going to call the CNA in and you're going to educate them. You're going to spend 15 minutes educating the CNA on whatever it is that you want to, and you're going to bill that treatment under, that education under one of those CPT codes. Because so whenever a resident is sick, you take the time to educate. You will never not render treatment and put an R on a log for a Part A resident. You should do this with your Part Bs too, because education is for every resident regardless. But I'm talking about Part A's for billing purposes because our window now, the rules for Part A's have changed. Not only do we have PPS assessments, we got other assessments. And a Part A patient is what you need to know is in an assessment every single day. So you will never write refused on a log. And if a resident is not sick, and you go in the room and say, Ms. Jones, come on, we're going to get ready for therapy. I don't want to go to therapy. When a resident starts to refuse treatment as a therapist, your job is to do what? It's to educate. So what mode, you're going to switch into that educational mode, and you're going to say, you know, Mr. Jones, I know that you love fried chicken, because you said, you know, that was like your favorite thing to eat. And the services that I provide, I can have you back eating fried chicken and catfish and whatever else. And after you educate him on why he needs your services and he participates, when you document, you're not going to say therapist had to encourage patient to come to treatment. You don't want to say that. You have to encourage a patient, or you say patient lacked motivation. Lack of motivation means they don't want it, and CMS sees that as they need to be discharged. What you're going to say is this: the therapist educated the resident on the benefits of receiving skilled physical therapy services to improve transfers in and out of the vehicle, participate in family outings. Patient participated in treatment. You don't have to tell Medicare that it took me 20 minutes to get him to actually do it, because what you did is you started educating him. That's what you do. Whenever a patient refuses service and say they don't want it, it is our job to educate him on the benefits of receiving the services, factors that he may be at risk for if he doesn't receive the services. And you have to document that. You have to document that. And if the resident actively participated after that, you don't have to say it. You just go on with your treatment. But if you educated him and he still didn't want to participate, you're billing for that education. So that's why you will never see a refuse on a log. And if you do, the therapist never did any education. They never told the resident what they are at risk for if they don't receive the services, because that's billable. So you should never put an R on a log for anybody. You may see some W's. W's mean withheld, that you're only going to withhold if they're not in the building, because you can't bill when the resident's not present, okay? But even if they're sick, if they refuse, you will never put an R. You will always at least bill a 15-minute for education. Yes. You can. You bill for that time. You bill whatever. If you can bill it under what, if you talk to them about if that's going to affect their gait, if that's going to affect their therapeutic exercise or neuromuscular rehab, because that's skillable, billable time. The time that you took talking to them about their blood pressure, educating them on it, that is billable. Anything you do with the patient that is related to their treatment is billable time. And you just pick a CPT code that you talked about the most, or of what it would affect the most, and bill it under that. And you need to document all of that in that daily note. Any more questions? Yes. Hold up, y'all. Let me get this mic. Ann, can you come help me with this? Right here, and then there's some questions.
Raise your hand. Who has a question?
What about when the family members affirm about you not treating their
Okay,
parent?
if the family member decides that they don't want treatment, they don't want the treatment, you have to stop the treatment that day. However, if you're in a Part A facility, you don't ever just take it upon yourself to discharge because there are some things that has to happen. There are some other things from the facility side that has to happen, like the advanced beneficiary notice. So what you say to the family member is, let me notify the facility. What you do at the moment that they say that, now make sure of this. When a family member says, I don't want the services, what are you going to do? You're going to educate them first. And you're going to document that you educated them and that you explain the risk factors to them that are involved if services cease. And after you do that and they still want to DC, that's what you say. Risk factor, educated the resident on the benefits of receiving the services, write out what they will be able to do, and the risk factors involved if services cease. You list all the risk factors. They could become contracted, they can have skin breakdown, they can develop aspiration pneumonia. You document all of that. And then if they still want, you say, after you've documented all that, family has been notified and is aware of the benefits and the risk factors and still wish to be discharged at this time. You better document because people are suing like crazy now, okay? And you can say, oh, I told them that, but guess what? Documentation is black and white. Either it's there that you told them or it's not. Next question.
How many times with the refusal, where we don't want to refuse, do we document the education?
You would document the education for a period of time. At least you need to, if you educated them, but there was no active participation in treatment, that's what you're going to document, okay? That you educated the resident on the benefits of the services so that they will be able to do da-da-da-da-da, explain the risk factors to the resident, and if you say resident at that time did not actively participate, when you say that now, let me say this, when you document the resident did not actively participate in a therapeutic activity, you should be getting ready to discharge. Okay. Now let me say this. It is very important that we give patients the benefit of the doubt. A lot of times, you guys, we don't take the necessary time to investigate why is this resident refusing services. A lot of times, it could be you. That you are not interested, you are not engaging the patient in the types of activities that they're interested in. You're doing the stuff that only you have interest in. You're doing things that because it's convenient. You got the little arch going on and the little pull. Residents get tired of doing that. Because I know if I'm ever in therapy and somebody gives me that arch thing, if you want me to do range of motion, you better hand some objects that I need you to reach, and one of them could be a cigarette, because I do smoke and I like to go outside to smoke. I will work with you. We have to find out what is interesting to the patient. Okay? Prime example, there was a patient that was PT and OT were working with in the standing frame on balance. And this man was like going down. It was like, oh, we can't work with him. We're going to discharge him. So the manager started talking to the patient, and they had those little cup things, move the cup from here to there, them little cones or whatever y'all do. The manager started talking to the patient. He used to own a club. So the manager goes, well, do you like playing cards? Yeah. So they got out a deck of cards, started playing spade with the man in the standing frame. He's been standing there for over 20 minutes and didn't even know he was standing. And he was not able to stand even 20 seconds. Now, how can you go from 20 seconds, or less than 20 seconds, he can't even stand, to over 20 minutes in one day? And this has been going on for weeks. They were ready to discharge. Shame on you. You have got to engage the patient, find out what interests the patient, and be creative and think outside the box. We have so many tools available to us that's in our day-to-day environment, but yet we'll choose to go with a ring toss or an arch or something like that these 80, 90-year-olds don't know anything about. And all you got to do is be creative and think outside the box and make it fun. Or make it part of their everyday activity. Go down to their room, OT. Go ahead.
And the next contestant on American's Idol. Now, let me ask you this. This code you keep talking, you're referring to the code. What's the code for this patient education?
The code is,
The billing code.
there is no education code. The education, you should be educating them on activities that would normally be billed under your neuromuscular rehab, therapeutic activities, self-care, swallowing. It should be billed, gait, it should be billed under those codes. Whatever, if I'm educating you on gait, you're gonna bill it to the gait. If I'm educating you on exercises, you're gonna bill it under the therapeutic exercise.
Okay.
Okay?
And how many days before you discharge them if they refuse over and over?
3 days.
3 days, okay.
Now, here's the deal. You make sure that you document that you educated them on the benefits and the risk factors. There is a lawsuit where a patient was receiving swallowing therapy. The family decided they didn't want any treatment. So speech therapy ceased. The patient later on developed aspiration pneumonia, sent him out to the hospital, and the patient died. Well, the family sued. So during the lawsuit, they asked for, and when there is an issue, anybody's name that appears in the resident's record, if you've never been deposed, you will be deposed. And they're going to ask you to recall information. This happened 5 years ago. I don't know about this patient. Go ahead.
If you're educating the family and the patient is not present,
Wait until I
Wait.
raise your hand, because everybody may want to hear. Oh, this is speech therapy. She talks, pretty
Go ahead.
loud.
if you're educating the family and they're not present, so you're having to call them, and the patient is not present, can you still bill for that
No.
education?
No.
So you need to have your patient present.
Education, the patient has to be present. So you will never educate a CNA in the hallway, you guys. The patient has to be present, okay? But don't, if you know there's a family member that's never in the building because they come at like 7 o'clock at night and you're never there, well, you're just gonna have to call them on the phone and basically educate them and document that in your note, but you won't be able to charge for that because the patient isn't present. Now, what you should do is call them while the patient's in the gym. And pull them up and say, you can put them on the speakerphone. If not, just make sure that the patient is there so they hear what you're telling the family member. You can bill for that. But if you're training a CNA in the hallway or just talking and not present, that's not billable. So you always want the patient to be present. If you have to attend a care plan meeting about your residents, you want to ask the facility, can you make sure that the patients are present? Because the time you spend in the care plan meeting talking about the therapy of that patient and the services, that's billable. That becomes billable time if the patient is present. And all patients has the right to be present during their care plan meeting. That is their right. Yes. Wait, Deborah's bringing the mic. So while Deborah's bringing the mic, let me get back to this SLP and the swallowing. So long story short, speech therapy never documented that she educated the family members on the risk factors if swallowing therapy does not continue. They asked the family, did the speech therapist tell you that this patient could develop aspiration pneumonia and die if you keep bringing this food in? No, they never told me that. Was going on the other side. Yes, I did. Yes, I did. But guess what? They turned to her and said, well, is it documented? No, but I know I told them. If it's not documented, it never happened. They lost the case. $3 million.
Okay, Nicole.
Okay, now in that same situation, what if the patient is not cognitively able to understand the risk factors, and you tell them you're at risk for aspiration pneumonia, but that person isn't able to reason.
Well, but that's fine, but if you're working with a patient like that, you shouldn't be telling that patient, because if that patient can't respond, that patient is probably not the one that's taking food off somebody else's tray. The food is being given to him by somebody. So you should be educating the caregivers, and you should be educating the family. If you have residents like that, and if they are doing it, you should be educating the CNAs. Please do not put a regular tray or do not sit him in the dining room next to somebody that's getting a regular tray. Because of his cognitive impairment, he's not aware and he doesn't understand the risk factors, and he's taking regular food off somebody else's tray. So what would you do? He needs to be sitting next to somebody that's on the same consistency. So if he happens to take it, he's not going to be at risk. So that's part of that cognitive training and adapting the environment that you do for dementia patients. So that's what you should be doing. It's whatever setting he's in, is you should be adapting his environment.
So if he refuses, just adapt his environment and charge that?
Yeah, because you still have to, I mean, if a patient refuses, especially an Alzheimer's patient, they're not consistent every day. Today, they may be 10%. Tomorrow, they may be 0. The next day, they may be 40%. The next day, they may be 80, because you know how they have those big spikes. Oh my God, but you know that's not realistic. So what you're doing is looking for an area that is, even if it's 10%, 10% is always better than 0. And when you are doing that, make sure you document, especially when it's a functional maintenance program and you're establishing that CMS wants to see what you tried and didn't work. Make sure that you document that. And you want to always document what didn't work, because we don't want another therapist coming behind you duplicating the same services, where if you had documented it, we would have known it didn't work. Now you just charge Medicare for something that we knew 2 weeks ago that didn't work. So, and they said that they want to see that. They want to see what worked as well as what did not work. So make sure that you do that. Any more questions? Okay. So that concludes the maintenance program. Any questions about that? So if a patient is sick or decides that he doesn't want therapy, what are you going to do? You're going to educate. Does the patient have to be present in order to bill for education? Yes, they do have to be present. Will you develop a maintenance plan for every resident on caseload? Yes. Why is a maintenance plan important? Why do you have to have that? To carry over and to ensure what? That the patient maintains that level at discharge. Yes. Deborah. Hold up, you guys. Wait a minute. Okay. You guys got to remember, if a patient is sick, you still have to educate.
Well, my question is, like, if they're lethargic that day and they're sick and lethargic, and you're educating, they're not even there because they're lethargic.
That's
they're
fine,
not alert or
but
responsive.
you still can educate the CNAs. You can talk to the CNAs
you
about
bring a CNA,
the
okay.
actual techniques. When a patient is
Okay.
sick, you're going to pull that CNA and say, come on down to Ms. Jones' room, with me. I need to discuss some techniques for you, because even when a patient is sick, there are things that need to be done that you're not going to do the same way if they were up, right? It's going to be totally different. You're going to educate that CNA on that. Remember, when you're doing education, you don't necessarily have to move the patient to do education. The patient just needs to be present. And when you are discussing the techniques with the CNA, okay?
But they have to be lucid. They can't just be in the room. They have to be aware that they're being talked about.
Yeah, and you're going to say that. You guys, one of the things that you have to remember is this, is that even if a patient is blind and hard of hearing, if before you enter a resident's room, are you supposed to knock, yes or no? Yes. Will you knock even if the patient is deaf? Yes. That's the law, exactly. So even if a patient is sick, you still will say, when you bring that CNA in the room, whether that you're going to still go through the motions of talking to that patient just like you would if they weren't sick. Ms. Jones, even if a patient is deaf, you're going to say to him, Ms. Jones, the CNA and I are going to be discussing your care. And I'm going to be educating her on some techniques that she can use with you and how to better take care of you. Okay? And just because a patient is deaf, blind, sick, or whatever, you still have to follow the same rules in a skilled nursing home just like you would for any normal resident. You have to remember that. It is the same.
Do you have to document
Yes, you document.
the person's name you train?
Yeah, you can. You can put the person's name there. Now, I don't know what some companies, they have education training log where you don't put the patient's name on the log, they sign. And there's an education and training log, and you list what you train them on and that date because it's like a running log, and then that person signs. But you have to get with, and I'm not sure about Mid-South, if you all have a training log, or is it required that it's just be documented in the notes? Oh, you do have a training log. Well, there you go. Well, they have a training log, so you need to know your company's policy for that training log. So she has a training log. So if you have a training log where you obtain signatures of the patient the therapist that you told, you don't put the employee's name in your note. You just say CNA or nursing trained. And if you want to look at who was trained, you can go to that log and see who you trained. Okay? Anything else? Okay, all right, well, we're going to move on with CMS regulations. We got Deborah, I think we got, okay. All right. Okay, Medicare requires that the services bill be supported by documentation that justifies the payment. This is important. Documentation must comply with all legal regulatory requirements applicable to the Medicare claim. Now, did they say some? Did they say some, or did they say all? And when they say all, they mean all. Part of a documentation, well, I wrote the short-term goals, but the underlying impairment's not there, skills, services, bills since last, progress notes lacking. That's not all. Your documentation must support the claim. And remember all the definitions, and Medicare says that it must be of such complexity that only a therapist could have performed the services. You got to document like that. Okay, in documenting, the record should justify that the patient was under the care of a physician and that the physician certified the plan. That means they signed and dated it, and that the skills of a therapist were required. Medicare says that the services must not only be provided by the qualified professional personnel, but they must require the expertise, knowledge, clinical judgment, decision-making, and the abilities of the therapist that the assistant, caretakers, or the patient cannot provide independently. They also go on to say that even though a therapist skill may be required for safety reasons, if an unstable fracture requires the skill of a therapist to do the activity, that might otherwise be done independently by a patient at home, or the skills of a therapist might be required for a patient learning compensatory swallowing strategies to perform cervical articulations and identity changes in voice and breathing that might signal aspiration. After the person is judged safe for independent use of these compensatory techniques, the skills of a therapist is not required to feed the patient or check what was consumed. That's in the regulations. And how many times I have read SLP notes where they talk about feeding the patient. That's not skilled according to Medicare. And if you document that you fed the patient, because feeding is not in your scope of practice anyway. So you should never be documenting feeding. That's OT scope, is feeding. And when they're working on feeding, they're working on different compensatory strategies from hand to mouth, weighted utensils and things like that. Feeding, and there it is, and that's what CMS says. It is in the guidelines. It is not a skilled service, and it is not billable. Services are of appropriate type, frequency, intensity, and duration for the individual needs of the patient. So you got to make sure, y'all, and it should not be a cookie cutter. Every patient you evaluate is 5 times a week for 4 weeks. Now, it's always going to be 5 times a week, but some patients may be 6 weeks, some patients may be 8 weeks, some patients may be 4 weeks, especially if it's a dementia management that you're strictly picking that patient up just to establish a functional maintenance plan. You're going to treat the patient to figure out what technique worked, what doesn't work. When you figure out what works for that patient and document what worked and what didn't work, then you're going to start training the staff, and once they reach 100%, you go into, discharge. Whenever a patient plateaus and you have adjusted the goals, varied the activity, and know that it's a true plateau, or the patient has reached maximal functional level, or the patient has reached their long-term goal, you are going to discharge. Or if a patient flat out refuses. Now, you can't just DC, especially Part A patient, you got to notify your DOR, so the business office, and MDS has to be notified immediately. Because not only if a patient refuses, you want to get some facility people involved. You want to let social services know, you want to let the family know, you want to let the business office people know, because a lot of times we had some refusals where a CNA had a better relationship with that patient. The CNA can say, okay, Ms. Jones, come on now, I'm not playing, we going to physical therapy today. Patient gets up and goes down to the gym and works. So you make sure before you discharge that you document that you have used your resources in the facility as well. All right, and this is just a list of required documentation that's in the regulation. Physician orders. Now, let me talk about physician orders. Physician orders should read evaluate in it at some point. If it says a consult or a screen, that's not an evaluation. And remember, we talked about this a couple of months ago, I think, that if you get an outpatient order or you get a script and it says PT consult, you're going to call the physician and you're going to obtain an evaluation order. It must say evaluation. A lot of our homes from Part A's, they come back with pre-checked orders. That's fine as long as they're signed. But the key is this: do not ever evaluate a patient without having a written order first. Did y'all know that? I did a training and asked the therapist, how many of you all do the evaluation and then and write the order after you've done? Half the room raise their hands up. You should never do that. There have been instances where the physical therapist was doing an evaluation and something awful happened. Patient fell, had a fracture, had to be transmitted to the hospital. Now, you just have an injury and you're working with a patient now that you don't even have authorization to be touching the patient. You can never do an evaluation until you get an order, and it has to be written. So please, people, don't go down there and evaluate people and come back and write the order later. You can't do that. That is against Medicare law. Everybody got that? You can't do that. In order to do an evaluation, you must have an order already. You can't just go around evaluating people and getting orders later. That's not the way it's done. Everything we do must be ordered by a physician. Yeah, but you need to write it before you go do the evaluation. It needs to be written. It has to be written before you go and do the evaluation. You must see it in writing somewhere. And if you get the verbal order, you need to go to that chart, handwrite it, go do that evaluation. After the evaluation, come back and write your clarification order.
Sometimes they'll ask the PTA to come down and put a CPM machine on the patient.
Mm-hmm.
Come in over the weekend, and the PT isn't present to do the eval yet. I can't do that, can I?
And why should you?
They ask me to do it because they can't do it. And they need the CPM.
Well, what should happen is this, what should happen is, Okay, a patient comes in and there's a CPM machine ordered for the resident. Now, what the PTA can do is they can go in and do some education and training where they're training them on how to do it. She doesn't need an order for that. That's just training. So if you look at it that way, that she's just training them on how to basically do it, she can do that.
They can actually put it on them.
She can put it on them. She can train them on how to do it. She should have a nurse there. Okay. All right, so you got to have an evaluation order. You must have physician orders. You're required to do an evaluation plan of care. You must have, yes. His question was, go ahead. His question was, if a patient is admitted on a Friday evening with a CPM machine and the physical therapist assistant is there because nurses don't know how to put on a CPM, how to put the machine on. Can the assistant put the CPM machine on the patient? And the answer was yes. They need to have the nurses present because they're educating them on how to use the machine and how to apply it. They're not evaluating the patient or doing any of that. And they came from the hospital with an order for the CPM. Okay, so you must have an evaluation research progress reports, including discharge notes, treatment notes for each treatment day. These are the required documents for CMS. So, let's start with the initial plan of treatment. We're going to talk about medical and treatment diagnosis and onset dates. This is important. So, for a Part A patient, the medical diagnosis must be the diagnosis that resulted from the day. So, if the patient was hospitalized for CHF, that should be one of the primary diagnoses on your plan of care. If they had a CVA 4 years ago, that's not what they were hospitalized for. The CVA should not be the first diagnosis because you can write 3 or 4 diagnoses for a patient. It has to be the diagnosis for which they were diagnosed for that hospital stay. For a Part B, the medical diagnosis should be the one that best contributes to the problem that you're working on. So you can pick whatever you want, okay? And you should choose a diagnosis that basically contributes, that you think contributed to the problem that the patient has. Okay? For example, if you're working on contractures, you probably want to choose osteoarthritis or rheumatoid arthritis or something like that. Yes?
You have a patient coming back with the diagnosis of UTI. And speech therapist, we're looking at dehydration. Maybe that's the only thing with a patient with a documented dementia.
Okay. Let me say this. UTI and pneumonia. If UTI and pneumonia has been resolved, you can't use it. However, you will document, and we're going to get to it in the reason for referral, that the patient was documented with, the patient was hospitalized for a UTI. Now, we also know that UTIs and pneumonia can exacerbate other conditions, okay? So pneumonia and UTIs are the only 2 diagnoses that I know of. Now, if it's not resolved, because some people still come back on antibiotics, that is not resolved. You know if it's resolved or not if they are no longer taking antibiotics. But if they are taking antibiotics, you will use it. And you will say in your 700 when you're writing it up that the patient was hospitalized for a UTI or pneumonia and is still receiving antibiotics for the condition. But if they're not taking it, it's been resolved, you can't use it, but you're gonna use another medical diagnosis, and then the reason for referral, you're gonna document that the patient was hospitalized for pneumonia or a UTI, and this medical condition has exacerbated another medical condition, because that's what it normally does anyway. Okay. Are we good? Yes. Wait a minute, let Deborah bring the mic. Okay, go ahead now. Say it again.
ahead, of course.
If they have, say, rheumatoid or osteo, could
Start
you
over
also
again.
add it?
Start over again.
Okay. Part A, if the patient was admitted with dehydration and weakness or CHF and weakness, but they also have rheumatoid or some sort of arthritis that affects their function, can that go under the medical diagnosis, but just not the first? Or
Yes,
can
yes, you're absolutely right. It can go. But make sure that your first diagnosis should always be the primary diagnosis for what they were hospitalized for. And the reason for this, you guys, is that, number one, okay, let me say this, that you should have a system in your building. The DORs, when a Part A patient comes back, the DOR in the stand-up meeting should have talked to the Medicare nurse or the nurse in charge of the admission patients and say, we had a new admit yesterday. She was admitted with CHF, dementia, and UTI, and maybe osteoarthritis. The DOR and the Medicare nurse should get together, because the DOR should be telling her, okay, I know we're going to want to use CHF, and I know speech, if they pick the patient up, are going to want to use dementia or altered mental status. So we want those diagnoses to be number one and number two, and everything else can follow. When the DOR does that, she's going to come back to the therapy gym, and she should have it written somewhere, or you should have some form of communication, because everybody's diagnoses have to be the same. They all have to be the same, so you should have a system for the medical diagnosis. You don't ever just look in the chart and pick whatever you want. It doesn't work like that. Not for Part A. Not for Part A, it doesn't. For Part B, you can pick whatever you want that contributed to the problem. But for Part A, you cannot. Okay, let's move on to the Part B, treatment diagnosis. For A and B, it's the same. Your treatment diagnosis is the diagnosis that best describes what the patient is being treated for. So if your primary treatment is gait, you should have an abnormal gait as a treatment diagnosis. If it's aphasia, it's aphasia. Swallowing is swallowing. Now, let me talk about swallowing. For a speech-language pathologist, if you are say the patient was hospitalized for a hip fracture. That's the diagnosis. Aftercare code hip fracture. Because you know all of the hip fractures and things like that, you should be using the aftercare code. CVA should be an aftercare, not a 436. You know, we're not doing that anymore. It's all aftercare. So the speech therapists want to work on swallowing, but the patient was diagnosed for a hip fracture. Or the patient could have some cognitive issues related to memory. The speech therapists still have to put hip fracture as the primary medical diagnosis. Now, how are you going to link the swallowing or the memory problem to the hip fracture? You do it in the reason for referral. You're going to say ST. Patient was hospitalized for a hip fracture. Upon hospitalization, patient began exhibiting memory problems or chewing problems or difficulty swallowing. Now the memory and swallowing just got linked to the hospital stay, and the claim will be paid. Whenever you have to choose a diagnosis that has nothing to do with what you're treating them for, you always link it in the reason for referral. Everybody got that? Yes.
Oh, raise your hand,
Right here.
because everybody may have the same
Yeah.
question, so they may want to hear this answer. Thanks, Grace.
Occasionally, I notice in the doctor's P&I or the history, they'll list a diagnosis or two that actually isn't listed as an admitting diagnosis, but is pertinent to your treatment. As long as it's in the chart somewhere, can you use that?
Not just, yeah, you can, however, if you find something in the chart, and we do sometimes, if you find a diagnosis in the chart that's not listed on the medical diagnosis on the resident's face sheet, you need to get it to the medical records. You might want to take that chart up to medical records, show them this diagnosis so they can add it to the resident's list of medical diagnoses. Because a lot of times we see where a patient had a stroke 4 years ago, but it's in the history, but it's nowhere on those, it's nowhere listed in the medical diagnosis. And once they've had a CVA, they always have had a CVA. So when you find things like that in the chart, you want to always take that to the medical records. Now, swallowing. If you are working on swallowing, regardless if it was a hip fracture and you're treating it swallowing, if you're treating for swallowing, I know you all do a dysphagia medical workup. Your swallowing must be your medical and your treatment. This is swallowing only. If you're treating for swallowing, swallowing must be your treatment and your medical. So you should be obtaining a dysphagia medical workup. When you get that, that authorizes you. That's why it's called a dysphagia medical workup. Even if they've had a modified. Some people already come in with a dysphagia as a medical diagnosis. If it's already listed, you already can use it, but you need to follow your company policy. If they require a dysphagia medical workup, you need to obtain that as well. Okay, any questions? Over here, Deb. And how are we doing on time? How much time do I have before break? Okay. Okay. Okay, then.
My question is, let's say you have a Part A patient that has been hospitalized previously at a rehab facility, and their diagnosis was like the respiratory failure or something like that, and they've gotten over that, but they still have weakness, and the main diagnosis that the doctor admits them for is the weakness. And I know in some areas that, weakness can't be used as a diagnosis for that patient.
No, you should be using respiratory failure.
Okay. Even
Okay.
if,
Yes, you still should be using respiratory failure because weakness is not a medical diagnosis. And y'all also, let me clear this, Mid-South Rehab does not have a dysphagia medical workup. So still, you have to do, if they're admitted with a physician order for dysphagia, then you should be using that as your medical. Most companies, some companies, once you write your clarification order and list dysphagia with the ICD-9 and the physician signs it, that is authorization to use dysphagia as a medical diagnosis. But you need to make sure that it's included in your clarification order. I'm talking to OTs like y'all speeches. Okay, where are the speeches at? Where are my speeches? Right here, okay. Okay, yeah.
Yes, I have a question. I'm in a Part B assisted living, and so we don't have any admitting diagnoses. We just get nursing that says, hey, this person is weak. Can y'all start seeing them? And when their files aren't even complete, their family doesn't know any history when you call them, and they've got hypertension. That's the only thing wrong with them. What would you consider?
Using
They're just debilitated.
You don't have any, you need to review their medical records, because they do have some records there, and some of them do, with the nurses, none of them do? Well, I guess you would have to get it from the nursing report, or the family report, or the patient. If the patient says, I have high blood pressure, yes. Wait a minute, wait just a second, so.
I'm a Part B facility, ALF, and I created like a sheet to send to their primary physician, asking them to check off on a diagnosis that supports the need for skilled services. If you look in the LCD and CPT manual, I've got a lot of the ones that are frequently used and just put them down, and I fax it to the physician, or I call and speak to the nurse.
What facility, what area? Are you in Mississippi, Louisiana?
Biloxi.
Biloxi, you're in Mississippi, okay. Well, maybe she can fax her sheet that she's so nicely developed to the RCDs, or get it to Deborah, and Deborah will get it out to all of the assisted living. Go ahead.
I'm also in ALF, and all of our patients have to have a history and physicals before they're admitted to our building with Emeritus. And usually that's what we make a copy of, and the doctor is usually going to have the diagnosis is written there, and we go from there, or add it, like she said, if we need to.
Okay, very good. Okay, just the last thing, go ahead, I'm sorry.
A statement you made a few minutes ago about feeding. Could you compare feeding to a trial therapeutic feeding, because they are two different things?
But you're not doing a feeding, you're doing a trial diet. And you got to be careful with your choice of words. You're doing trial consistencies. That's not feeding. And you'll see the therapist will make a mistake and say trial feedings. That's not what you're doing. That's not scalable by, according to Medicare. What you're doing is trial consistencies. So make sure that you say that. Last thing, onset dates. The onset date for a Part A medical diagnosis is always the first day of the hospital stay. Everybody got that? My slide is missing for that. The onset date for a Part A medical diagnosis is always the first day of the hospital stay. Part B, the onset date is always the date that it was documented by nursing that the patient had a problem. Now, you say, I screened the patient. When you screen a patient and you find the problem, you must communicate to nursing that a problem has been identified. I need you to observe and document that this problem exists. And the date that it's done, and it only needs to be seen one time, that's your onset date. And if you find the problem that day, you give them the note to document that problem. They should document it that day. You can use today as the onset date. But it's always, because Medicare says everything we do must be supported by nursing documentation, and this is Part B. So if it's not documented that the patient is coughing on thin liquids, and you don't see that anywhere, you don't have supporting documentation, because when that claim is audited, they're going to ask for supporting documentation.